Now, this is absolutely important topic, and a lot of questions you can expect in your exam. Okay, but remember one thing: we don't always study for the exam. We study to gain knowledge. And when you go to the hospital, when you start working as a doctor, you realize how important is this topic. And one more thing I like to talk: these days, okay, in many families, people are dying suddenly. There is sudden death happening everywhere. And the number one cause of sudden death is ischemic heart disease or coronary artery disease. So it shows the importance of the topic. Now, ischemic heart disease is also known as coronary artery disease. And in this condition, cardiac ischemia occurs secondary to coronary artery disease. That's why the synonymous term CAD or coronary artery disease and ischemic heart disease. This coronary artery disease is the number one cause of death all over the world. If we take the combined data from the developed countries and developing country and analyze it, the most common cause of death all over the world is myocardial infarction, and myocardial infarction is a type of coronary artery disease. Now, if we analyze individually, that data may differ. In the developing countries, still infectious disease are the number one killer. In the developed countries, probably coronary artery disease and along with them cancer are the number one killer. And let's not forget the role of accident as well. So all of these we can discuss some other time, but related to this class, this is number one cause of death all over the world. Now, what is the common age group? The most common age group is middle-aged men and post-menopausal women. So middle-aged men, from that time, it starts, and of course older men are also equally affected. And in case of female, they are affected after the menopause. Okay, so what is menopause, guys? What is menopause?
No menstruation.
Inhibition of menstruation cycle.
Stoppage of menstrual cycle.
Exactly.
Inhibition of.
Very good. Very good. So all the students know this. Okay, excellent. Menopause is stoppage of menstruation. Stoppage of menstruation. This is a permanent stoppage of menstruation actually. So after that, there is no estrogen secretion in the female body, and that estrogen is protecting them against atherosclerosis and this type of disorder. Now they lose that protection after menopause, so they are equally vulnerable like men. So this is very important point. Now let's classify what are the types of ischemic heart disease here. The important types are angina pectoris, myocardial infarction, chronic ischemic heart disease, and sudden cardiac death. So regarding the angina pectoris, we have three types: stable angina, unstable angina, and Prince-Metal's variant angina. In pharmacology also, you must have studied this before, so it is a bit easy for me. Angina, stable angina, unstable angina, and Prince-Metal's variant angina. Now, myocardial infarction is the most severe condition among all of them, and if the blood flow is not completely blocked, but it is lesser than the required amount, then over a period of time, this patient will develop chronic ischemic heart disease. There is atrophy of the affected area, and the last one is a very, very serious sudden cardiac death. Okay, within few hours, the patient is going to die. For example, the chest pain occurs or some onset of the disease occur, and patient is no more. The most common cause of sudden death these days, coronary artery disease. Look at this picture here. It will teach a lot of knowledge for you. This is how chest pain occurs in case of ischemic heart disease. It is in the precordial area. This is called precordium. It starts from the retrosternal area, then probably it is radiating on the inner part, on the left side. Inner part of the arm on the left side, it may reach the forearm area, and sometimes even the backside or towards the shoulder. This is a ischemic pain. Okay, let's continue. We are talking about ischemic heart disease or coronary artery disease. Now, before the break, we classified about them, and the classification is angina pectoris, myocardial infarction, chronic ischemic heart disease, and sudden cardiac death. And they are the #1 cause of death all over the world, especially myocardial infarction and sudden cardiac death. Now, before we move further, let's talk about what is exactly happening inside the coronary artery. This is called schematic representation of sequential progression of coronary artery lesion morphology. So how it starts and what happens so that the patient gets all these different type of coronary artery disorders. Now, let me start with atherosclerosis here. I'm not sure whether you have done this before or not, but some of the important point I'll highlight in today's class. In 90% of the time, atherosclerosis is the main culprit for coronary artery disease. Now see there, this is the normal coronary artery. It has got 3 layers like any other arteries. Intima is the innermost one, media is the middle thicker layer, and adventitia is the outer one. So this is the lumen. Now you can clearly see on one side of the lumen, okay, from its inner wall, there is a growth here, okay, there is a mass, you can say. This is called atherosclerotic plaque, or we also call it atheroma. This atheroma is a lipid deposition on the tunica intima. Now later on, it is not only lipid now, okay, it has also fibrous tissue, it has also necrotic core, and it has some smooth muscle element as well. Now listen carefully. It starts with a lipid deposition, but ultimately it doesn't have only lipid. It has so many other things. It has fibrous tissue, it has necrotic core, and it has inflammatory cells. Along with them, it also has a smooth muscle component. Now, the risk factor of this atherosclerosis or atherosclerotic plaque formation are, okay, so many. We divide them into modifiable risk factor and non-modifiable risk factor. Now, non-modifiable means we cannot do anything. They are already there. We cannot even run away from them. Like age. Age is important one. Sex. Okay. Male are more commonly affected than female. Then family history. Okay. If a father or elder brother or even grandfather, if they are dying with coronary artery disease, there is a high risk that other member may also die. This is a very, very important point. Okay, so we cannot even change them. These are non-modifiable risk factors. Now, among the modifiable or controllable risk factors, we have smoking, diabetes, hyperlipidemia, and hypertension. Smoking, diabetes, hyperlipidemia, and hypertension. These are the very, very important controllable risk factor, because we can do something to control these. The person can quit smoking, the person can control the level of lipid, the person can control diabetes, and even blood pressure. So all these are very important points. Okay, now, okay, now see here, those risk factors are already there in this person, and the atheroma is already formed. Now what that atheroma is going to do? If this coronary artery is about 70 to 80% block, then angina will occur. This is known as stable angina or typical angina. So this coronary artery is already 70 to 80% block only, okay, 20 to 30% lumen is open. So if this person is doing exercise, a little bit of strenuous type of exercise, for example running, okay, either outside or running on the treadmill inside the gym, or this person is climbing a mountain, for example, during that time the demand of the blood from the body, okay, is excessive. Now our heart, okay, need to pump the blood faster and stronger to meet that demand. So heart also needs blood during that time. Heart needs more blood than before, but that cannot happen because coronary artery is only 20 to 30% open. 70 to 80% is already blocked, and we develop chest pain. Okay, we develop chest pain only during this situation. This is called stable angina or typical angina. And when the person takes rest, okay, again there is a balance between demand and supply, and there will be no chest pain. This is a very typical symptom. We'll talk about that later also. Now, somehow, if this atheromatous plaque is ruptured, somehow if it is ruptured, let's talk like this. And the common causes of rupture of atheromatous plaque are hypertension and smoking. Hypertension and smoking, and one more. These days they are doing a lot of research on this field, and they have found out that stress or stressful situation in our life is another very important factor for the rupture of this plaque. Now what will happen after this rupture? See here, the platelet will aggregate and it will quickly form a thrombus. The artery is already 70 to 80% blocked. On top of that, if a thrombus is formed, okay, if a thrombus is formed, then it can have two important consequences. Now see here, it can completely block. See there, I cannot see any opening now. Whole lumen is completely blocked. That will give rise to transmural type of myocardial infarction or even sudden death. Transmural myocardial infarction or sudden death. And if this rupture of the plaque and thrombus formation leads to critical occlusion, but still a bit of area is left behind, it will give rise to unstable angina, okay, unstable angina, or another type of MI which is called subendocardial MI, and even sudden death. And one more thing is left now. If this coronary artery is critically obstructed, for example more than 90 to 95%, but still some amount of blood is flowing, and this is a chronic type of process, then we call it chronic ischemic heart disease. In this condition, the affected area will be atrophied. Okay, it won't die, but probably it will get atrophied there. So these are very, very important point in case of coronary artery disease. And these three things together, unstable angina, two types of MI, subendocardial MI and transmural MI, they are called acute coronary syndrome. This is a very important clinical term, acute coronary syndrome. Now with this knowledge, let's enter into the angina part. Now, what is angina and what are the different things? Let's talk about it. Angina pectoris is a common symptom which is often experienced as a heavy, strangling or pressure-like pain. Strangling or pressure-like pain sometimes may feel like hyperacidity as well, especially in case of epigastric area, we may feel like that. And the common site for that is substernal or retrosternal area, behind the sternum, okay, behind the sternum, or precordium. Precordium is the area which is in front of the heart. Precordium, pre, in front of the heart. But sometimes the pain radiates to the left shoulder. See here, flexor aspect of the left arm, flexor aspect of the left arm, even the jaw, neck, and epigastrium, or even the back. Most of these are towards the left side. For example, flexor aspect of the left arm towards the left jaw, left side of the neck, okay, epigastric area, or even back side, slightly on the left again. So this is called angina. So let me explain this once again. The patient may come to the hospital with this type of description. Doctor, I suddenly develop a severe pain exactly behind my sternum, and the patient uses palm. Patient uses the whole palm to show that pain. If we ask, where is the pain? Can you show me? the patient use the whole palm to show the pain. They never show the pain with one finger because big area is affected. And that pain is strangling or pressure like pain, okay, or something is pressing it very tightly. And there are typical radiation. This is called anginal pain. It usually lasts for 1 to 5 minutes and is relieved by rest or specific anti-angina medication. Now, this pain doesn't last longer because after this severe pain, patient will take rest, and after rest, the pain will disappear. Now, what are these anti-angina medication which the patient will take? Anybody? What are those medicines?
Nitroglycerin.
Very good. Very good.
And sir, in case of metal angina, we also give calcium channel blocker.
Exactly. So nitrate or nitroglycerin, both are correct answer. Nitrate or nitroglycerin. Okay. Then calcium channel blocker. You're right. Calcium channel blocker. Okay. Calcium channel blocker as well as beta blocker. Beta blocker. Exactly.
The beta blocker are contraindicated in presmetal angina.
Exactly. We'll talk about that. Okay. But if we ask about the common anti-anginal medication, you must say beta blocker. Later on, you can add they are contraindicated in presmetal angina, but they are very commonly used in other type. But having said that, the most important types of anti-angina drug is nitroglycerin or nitrate. That is taken sublingually, and within minutes, the pain will disappear. So this is a typical history of angina. The pectoris term here is used for the chest because pectoralis major muscle there, so we use the term pectoris. Now, there are three varieties of angina pectoris: stable angina, unstable angina, and variant angina. So let's talk one after other. Stable angina is the most common type of angina in comparison to other two. It is very common, most common type. And it is caused by coronary artery atherosclerosis with luminal narrowing greater than 75%. Okay, that's what I was explaining earlier. If 70 to 80% of the blood vessel is already blocked, okay, in case of coronary artery, we have a high chance of having a stable type of angina. Now, when the person is taking rest, there is no chest pain here. Please remember this. At the time of rest, no chest pain. Chest pain occurs only when there is increased cardiac demand, and that increased cardiac demand is brought by exertion or emotion. Exertion or emotion, especially exertional activity like exercise is the best example we can give it here. And the person is very afraid or frightened to have that type of pain. These days, people are very conscious, people are educated, they have free or easy access of internet. They can quickly check what's going on in me, and by the time they see this, they are very afraid and they immediately go to the doctor. Okay, but remember one thing, when we do ECG and that time there is no chest pain, there is no ECG finding. ECG finding occurs only at the time of chest pain, and that ECG finding is ST segment depression. ST segment depression. This is a very typical ECG finding in stable angina. But let me repeat again. So many of the patient, okay, because the pain doesn't last longer, maybe 1 to 5 minutes. When they reach the hospital, the pain is no more there. And when the doctor do ECG, nothing comes positive. It is absolutely normal ECG. But that doesn't, rule out ischemic heart disease. We diagnose this mainly from the history, the typical history, and then certain investigations will be done later on. One of the important investigation is called coronary angiography. Another is called treadmill test. We ask the patient to do heavy running right in front of us, and during that time we attach the ECG lead. Okay, when the patient reaches that critical stage, okay, there is an imbalance between demand and supply, he starts to have chest pain, and we can record that ECG finding. So that will confirm, yes, this patient is having stable angina. Now, the important point many students already know, this is relieved by rest or nitroglycerin, because nitroglycerin is a type of vasodilator. It will increase blood flow to that coronary artery. Okay, this is important point. So, angina pectoris.
वाली ये चल जाएगी ठीक है
Okay, now let's please mute yourself. So all other types of angina pectoris are Prinzmetal's variant angina and unstable angina. So let's talk one after other. Now this Prinzmetal's variant angina is not associated with atherosclerosis. The mechanism is somewhat different. This is caused by vasospasm, okay, vasospasm or vasoconstriction of coronary artery. So it can also occur at rest. There is no relation with activity here, and this chest pain is unpredictable. We don't know when it is going to occur. If we do ECG during this episode of chest pain, now the ECG finding is different. It is different from stable or unstable angina. There is transient ST segment elevation here, okay, and this shows the whole thickness of the myocardium is getting ischemic, which is known as transmural ischemia. Transmural, whole wall, whole thickness is ischemic. And this condition is treated by, okay, it is treated by nitroglycerin again, because it will lead to vasodilation. But you all know, probably it was taught in pharmacology, beta blocker are contraindicated in Prinzmetal's variant angina, because that beta 2 receptor is maintaining the dilation of the blood vessel. It is dilating the blood vessel. If we block those beta 2 receptor, then opposite type of effect will happen. That's why don't use beta blocker in case of Prinzmetal's variant angina. You can use other medicines like calcium channel blocker or nitroglycerin. The third one is unstable angina. Now we are going to a more severe variety here, and this is caused by the formation of non-occlusive thrombus in an area of coronary atherosclerosis. Now I have already explained this to you. In the beginning, atherosclerosis is formed. This atherosclerosic plaque will rupture, okay, and the common etiology of rupture is smoking, hypertension, and stress. Smoking, hypertension, and stress, or stressful condition. After that, on that ruptured area, a thrombus will form. This is mainly platelet thrombus. Now this thrombus will not cause complete occlusion of that coronary artery. Remember this, if it causes complete occlusion, then transmural myocardial infarction will occur. But this is a case of unstable angina, so it doesn't cause complete occlusion. But it will make that coronary artery very narrow, probably 90% or even 95% narrow. Now what will happen? Chest pain can occur even at rest. Chest pain can occur even at rest, or even with very minor type of activity. And those chest pain are, okay, they occur very commonly or very frequently. Their intensity is increased. I mean, they are more severe than before, and they are even longer than before. Earlier, if they occur for 5 minutes, now they can occur for 10 minutes or 15 minutes. Earlier, if they occur maybe once a day or twice a day, now they can occur 3 or 4 times a day or even more longer. And the chest pain is also very, very severe. Now clearly, this unstable angina is a warning sign for upcoming myocardial infarction. And when the person, okay, when the person neglect completely about the situation, do not go to the doctor or something like that, then myocardial infarction will definitely develop after some time. This is a very, very important point. So we take it as a warning sign for upcoming myocardial infarction. Now, this is the pathophysiological mechanism of angina. Now see here. Angina is all about imbalance between demand and supply of oxygen. So this is oxygen consumption and this is oxygen supply. Clearly, in this case, the oxygen consumption is more than the supply. That's why ischemic pain occurs, okay, in our chest. Ischemic pain occurs in our chest, which is caused by myocardial ischemia. So this is a very important concept. Never, forget this. If there is a good balance between consumption and supply, there will be no chest pain, and that exactly happen when we give nitroglycerin or when the person takes rest, because there is no extra demand now, so the supply whichever the patient is getting is enough for that demand. So always there should be a balance, then there will be no chest pain. Consumption is more than supply, there will be chest pain. This is the principle of angina. Now see here, this is a picture which is coronary angiography. This coronary angiography has one very important finding here. You can see this arrowed area, okay, this area. This area is narrow. Here the lumen is quite good, okay, but here it is narrowed and here it is very, very narrowed. See here, acutely narrowed. This is known as coronary angiography. Now angiography means we give some dye, okay, these are called radio contrast dye, a radio contrast material into the vein, and this dye will go everywhere, but we take X-ray of only that part which we want. So in this case the coronary circulation, and we are taking X-ray and we can see if certain amount of dye is not flowing properly in that area. See, here it is not flowing, so we know there is obstruction here. So after this the treatment is very easy, okay, treatment is very easy. There are two types of treatment now. One is called percutaneous coronary intervention, percutaneous coronary intervention or PCI. So what they do, okay, this is they make it wider and they put a stent there so that this bypass, this obstruction is bypassed. Another is called CABG or coronary artery bypass graft, a completely different type of surgery and a bit complicated one as well. Now with this, let's talk about myocardial infarction. Myocardial infarction is a localized area of cardiac muscle necrosis due to ischemia, isn't it? Infarction is ischemic necrosis. So myocardial, okay, infarction is cardiac muscle necrosis due to ischemia, and that is in a localized area of the heart. Now our heart is supplied by two coronary artery, right coronary artery and the left coronary artery. But left coronary artery will immediately divide into two further branches, LAD and LCX. Now LAD is left anterior descending and LCX means left circumflex. So in some of the textbook it is also mentioned there are three coronary arteries because they are counting one for each of them. Okay, so whatever way you answer, that will be correct, but just take the name of these arteries, that is RCA, right coronary artery, LAD, left anterior descending, and LCX is left circumflex. Now see here, this is the most common cause of death all over the world, we already know that, and there are two types of myocardial infarction. They are transmural and subendocardial. What is the difference between them? What is the meaning? So, transmural means whole thickness of the wall is infarcted, and subendocardial means only a part. Okay, please remember like that. But if we want to explain in a bit of detail, then the ischemic necrosis occurs in more than 50% of the myocardial wall. more than 50%, okay, then it is called transmural. Sometimes even the near full thickness myocardium is affected. Not always the full thickness is affected, but according to the definition, if it is more than 50% of the wall, then it is called transmural infarction. On the other hand, subendocardial infarction is a ischemic necrosis of less than 50% of the myocardial wall. This is important point. Transmural and subendocardial. So of course, transmural is much more severe than subendocardial one. Now, among those coronary artery, left coronary artery is affected more than the right. So these are all very important MCQ question in the exam. And left coronary artery has two branches, LAD and LCX. So LAD is the most commonly affected artery. So please try to remember this. Now, those arteries which I was talking about, okay, you can clearly see here in this picture. See here now. So this is the ascending aorta. This blood vessel is ascending aorta, and these are the coronary arteries. See here. Okay, this is left coronary artery, and this is a stem of left coronary artery. It will immediately divide into two branches. This is LAD, okay, left anterior descending, because this is the anterior surface and it is coming downwards. Very easy term, left anterior descending, LAD. And another is circumflex. Circumflex means it is going like this on the back side, okay, going like this from the side on the backward. So this is circumflex, left circumflex artery. And another is right coronary artery. So these are the main coronary arteries. And if they ask which is the most common artery that is affected in case of coronary artery disease, you always answer this one. LAD is the number one affected artery. Now, let's talk about what are the important age group and what are the common risk factor for myocardial infarction. Okay, by this time, many students know this already, but knowing is one thing, okay, and implementing that in the practice is another. Always remember this. That's why we say, you know, when we teach our medical students, we always mix theoretical knowledge is one thing, practical knowledge is another, and a good doctor is that which mix both of these things together. You must be a wonderful, you know, a person in the knowledge, but if you do not know how to examine the patient, what's the use of that? And also, if you know how to examine the patient, but if you don't have knowledge, you don't have any differential diagnosis, you cannot even think about what can happen, what is the management, that is also not a good doctor. So we need both of these. What I'm saying here, okay, let's know this properly and let's know the importance of this as well in the patient's life. So incidence rises progressively with increasing age here. It starts from middle age, but even older age people are suffering from myocardial infarction. Nearly 10% of myocardial infarction occur in people under the age of 40 and 45% occur in people under the age of 65. You see that? This clearly tells us, okay, that majority of the people are relatively older. Hypertension, cigarette smoking, diabetes mellitus, and hypercholesterolemia or hyperlipidemia are the most important risk factor in myocardial infarction. Now, these all are called potentially controllable risk factor. We can control them. Yes, they are very scary. Okay, if a person is having all four of these, then the span of life is very short. If the person is hypertensive, if the person smokes heavily, if the person is diabetic, and if the person is also having increased lipid level, then the lifespan is very short. The person can die anytime because of atherosclerosis and related complication. other types of risk factor which I already discussed before are called non-modifiable risk factor. And a very sad point about this is the person who has never smoked in his life, the person who is not diabetic, the person who is not hypertensive, and his lipid level also normal, can also die because of those risk factor like family history. Now this is very difficult to believe and very difficult to accept as well. If this thing happened in our family, or with us, this is unacceptable, but we cannot do anything because these are the risk factor which we do not have any control. But having said that, the chance of death from those non-modifiable risk factors are far less than these modifiable risk factors. That's why these are important. Throughout the life, men are at significantly greater risk of MI than women. The differential progressively decline with advancing age. And see here, ischemic heart disease is the overwhelming cause of death in elderly women. Already told you this important point. After the menopause, the risks are equal in male and female. The advantage which is given by that estrogen is gone. So they are equally vulnerable for the atherosclerotic mechanism. So even older female are dying because of ischemic heart disease or myocardial infarction. Now let's talk about pathogenesis of myocardial infarction. Now if you remember the one slide which I discussed before, the pathogenesis related things are from that slide itself, but still let's talk this in a bit detail here because this is a very important question and important knowledge for you. In the typical case of transmural MI, in almost 90% of the case, the following sequence of event can be proposed. So these are the things which are happening inside the coronary artery. In the beginning, there is a formation of atheromatous plaque, and atheromatous plaque formed because of those risk factors. The person may be a smoker, person may be hypertensive, hyperlipidemic, or having diabetes, or maybe family history. Now what happens? There is sudden disruption of an atheromatous plaque, means it ruptured now, and it will manifest as intraplaque hemorrhage, erosion, or ulceration, or even fissuring. So these all are called rupture of atheromatous plaque. Now you have studied thrombosis chapter in basic pathology. This is a part of our endothelium. If endothelium is injured, there is high chance of thrombus formation. The same thing happens here. So after it ruptures, there will be exposure to subendothelial collagen and necrotic plaque contents. Now what will happen? Platelet will come into the action. They undergo addition, aggregation, and activation. This is how platelet thrombi forms. And during that mechanism, they release a lot of aggregator like thromboxane A2, thromboxane A2, serotonin, and other platelet derived factors. So let me explain again. After this atheromatous plaque get ruptured, there is exposure to subendothelial collagen and necrotic plaque content. They attract the platelet towards that area. Platelets get attached there. They are aggregated and they are activated. They release furthermore substance from them like thromboxane A2, serotonin, and platelet activating factor. This thromboxane A2 is also a type of vasoconstrictor. Now, vasospasm is stimulated by platelet aggregation and the release of mediator, mainly thromboxane A2. So further vasospasm will occur here. Now what will happen? Within a minute, this doesn't take longer, within minutes, the thrombus will completely occlude the lumen of coronary artery, because it is rapidly, enlarging mass. So within minutes, that thrombus will completely occlude that coronary artery. Remember, 70 to 80% of the artery was already blocked by atherosclerosis. Only 20 to 30% was left behind, and that space is also completely occluded by this thrombus. Now, what will happen next? Okay, the same picture. Okay, so let me highlight this picture again to you. What I was talking about here is exactly this one. Now this is the rupture of the plaque. Okay, then there is a formation of thrombus. This thrombus has completely occluded that open area inside the coronary artery, which results in acute transmural myocardial infarction. If it doesn't occlude completely, then other possible things will occur. Now, in another 10% of the cases, the transmural acute myocardial infarction is associated with some other mechanism. It is not caused by atherosclerosis. In 90% of the time, that atherosclerotic related reaction has occurred, which we already discussed. But remaining time, it may be caused by vasospasm. Okay, it may occur with or without coronary atherosclerosis, but usually without. Emboli, okay, emboli are mainly coming from the heart, and unexplained mechanism like vasculitis or hemoglobinopathy or amyloid deposition inside the vascular wall. So 10% of the time, these are the related causes. 90% of the time, it is atherosclerosis. Okay, good morning everyone. So let's start the class. So today I'm going to continue the discussion regarding ischemic heart disease. The most important part or type of ischemic heart disease is myocardial infarction, and this is the #1 killer all over the world as well. And that's what we are talking from yesterday's class. So let me revise a little bit and then move further. Now, myocardial infarction is caused by atherosclerosis in 90% of the time. Now, not only atherosclerosis, after the rupture of that atherosclerotic plaque, there is formation of occlusive thrombus, and it will completely block the flow of coronary artery, which leads to transmural type of myocardial infarction. That is the most severe and more common as well. Whereas if still a bit of blood is flowing to that area of the heart, but it is, severely constricted or narrowed, then subendocardial myocardial infarction can occur. Along with that, even unstable angina can happen. Okay, unstable angina and subendocardial MI, there is a massive difference, though the pathogenesis is same. Remember that pathogenesis is exactly same. So what is that pathogenesis? In the beginning, there is atheromatous plaque. That plaque will rupture. There is formation of thrombus, but it is called non-occlusive thrombus. Still a small part is left behind in the lumen of coronary artery. So both of these conditions, like unstable angina and subendocardial MI, can be caused by the same mechanism. But angina is reversible condition. Till now, there is no death of the myocardium occurred, but infarction means ischemic necrosis of the heart muscle. That is a big difference. And let me tell you some important points immediately. If we check the cardiac biomarker or cardiac enzyme, they are only raised in MI or myocardial infarction. They are not raised in angina. So if you have a slight amount of doubt, you can go for those type of tests. Whereas in rest 10% of the time, atherosclerotic plaque is not responsible for myocardial infarction. That is also very important knowledge for us. Then what are those causes? One is embolism. embolism, and emboli are very commonly, originated from the chamber of the heart, like left atrium in case of mitral valve disease. Left ventricular disorders can cause formation of thrombus inside the left ventricle wall, okay, and that can detach and lead to embolization. Very, very rarely, some emboli are called paradoxical emboli. They originate from the deep veins of our lower limb. They go towards the right side of the heart. Then through the defect in the septum, they can directly go towards the left side of the heart and then cause the problem. This is called paradoxical emboli. Very rare condition, but importantly asked in the exam. So emboli is one. Second, vasospasm of coronary artery itself can lead to myocardial infarction. Okay. Some other are vasculitis disorder. Vasculitis, like connective tissue diseases, can also lead the same type of condition. So always remember this: atherosclerosis 90% of the time, 10% of the time something else apart from atheroma. Now these are the things which we discussed yesterday. Let's move further now. There are two types of myocardial infarction: transmural and subendocardial. Now transmural means more than 50% of the wall, okay, more than 50% of the thickness of wall is affected, and sometimes the whole thickness of the wall is also affected. So it is usually associated with coronary atheroma, acute plaque change, rupture, and superimposed thrombosis, and this is completely occlusive type of thrombus. Then only transmural infarction can occur. Whereas subendocardial, also known as non-transmural infarct, and in that condition less than 50% of the wall is affected. Less than 50% of the wall is affected. One important point here: the subendocardial zone, okay, of the heart is normally the least well perfused region of myocardium, and therefore is most vulnerable to any reduction in coronary flow. And this is the reason why, even without complete occlusion of the coronary artery, there is death of the myocardium in that area, because it is already very least well perfused. Now, subendocardial infarct can occur as a result of plaque disruption followed by coronary thrombus. So many times I explain this point because it is extremely important concept. There is non-occlusive thrombus. Still some amount of blood is flowing into that area, but that is not enough. That's why there is death of myocardium. Subendocardial infarction can also result from sufficiently prolonged and severe reduction in systemic blood pressure, like in shock. Okay, shock, hypovolemic shock, septic shock, cardiogenic shock, anaphylactic shock, and neurogenic shock. We have 5 different types of shock. So any of them can result in low blood pressure, and we are having problem regarding this subendocardial zone of our heart, because this is already least well perfused, so it may suffer from infarction during that time. Now let's talk about the interesting part of the lecture. What are the clinical manifestation or clinical feature? The most important clinical feature is severe chest pain, sudden onset of severe chest pain, and the patient explains that chest pain as a crushing type of pain. Okay? And usually some of the patients describe that I am feeling one heavy weight which is kept on my chest. And in some of the textbook it is also written like, an elephant is there on our chest. So think about that type of condition now. So same type of feeling is, okay, there in the patient. This pain occurs in the retrosternal or substernal area, and it often radiates to the left arm, jaw, as well as neck area. Okay. Towards the left side is more commonly radiated. Very rarely it can radiate to the right side as well. There is heaviness of the chest and tightness of the chest sometimes. There may not be severe pain. Sometimes just the patient feels heavy chest or tightness of the chest and shortness of the breath. Now these are very difficult to diagnose. Patient may think something else. If that patient is also having bronchial asthma, then patient may think I'm having the attack of bronchial asthma, so let's take a bronchodilator drug. So they never think of some serious condition like MI. Okay, so this is a little bit atypical type of presentation. And one important point I like to highlight here, sometimes the patient feels pain in the epigastric area, and this is a burning type of pain. So many people are confused, this pain is because of peptic ulcer disease, but actually this is because of myocardial infarction. Now listen carefully, what happens now? Even family member think, okay, this may be a peptic ulcer disease pain. So what is the treatment of peptic ulcer? We all know H2 receptor blocker, PPI, antacid. Sometimes they may give some ice cold water or something in the house, isn't it? That's what they do. But this is a fatal mistake they are doing, because this is MI, and if this patient doesn't go to hospital in time, there is high chance of death. Because of this reason, so many people die at home or on the way to hospital. One of the very, very important manifestations of myocardial infarction is excessive sweating, also known as diaphoresis. Okay, sometimes the patient do not complain. Remember that patient may be of different nature. Sometimes even if they are having severe pain inside the body, they don't make noise. They don't want to complain to other people. They may bear that pain, but there is excessive sweating going on from the forehead or sometimes from the whole body. And if the family members are well aware of the situation, they should ask the question to themselves, why he is sweating so much? There must be something horribly wrong inside him. Okay, so this will give us the clue, but we need to think about it. If we do not know, if we have not heard about this type of thing, then how can we think, isn't it? So this is the very important point here. Some people may develop nausea, or some people may vomit as well. Whenever there is severe pain in the body, we may develop vomiting. So this is a non-specific symptom. One more feature, this is examined by the doctor actually. There is raised in JVP, or jugular venous distension may be there. And many people think this is the end of my life now, I am going to die because of this severe pain. I am already having heart attack. Okay, I cannot even survive even after I reach the hospital. That type of feeling is there. This is known as anxiety and a feeling of impending doom. So these are important features of myocardial infarction. Now, how to diagnose it? Okay, let's give you a little bit more knowledge here, because this is a very, very important topic. When this type of patient comes to the hospital, as a doctor who are working in the emergency room or in the hospital or in the clinic, wherever, we need to do certain tests. One of the most important tests is ECG. Quick and immediate ECG should be done. ECG, also known as EKG. In the United States, they call it EKG, and in the UK, they call it ECG. Okay, whatever you like to call it, it's your choice. Both are correct term, EKG or ECG. Now, if the pain is still there, even if this is a case of angina, the ECG changes will occur. But in myocardial infarction, we don't care whether the pain is there or not. The ECG manifestation will remain, because heart is permanently damaged. So the ECG changes will remain there. Later on, okay, after many days or many weeks, those ECG changes will disappear. Only one ECG change will remain, and that is Q wave. We'll talk about that later. But right now, what I'm saying, within few hours, if the patient was brought to the hospital, still the ECG changes we can see there if it is a case of myocardial infarction. And what are the ECG changes now? There are two types of MI. One is called subendocardial MI, another is transmural MI. In subendocardial MI, there is ST segment depression, and in transmural MI, there is ST segment elevation. This is the difference. One is depression, another is elevation. Along with that, there is some changes in T wave also. That is one thing. The another is cardiac enzyme. So these are the cardiac enzyme which are normally done if we suspect myocardial infarction. Now let's talk about them. CKMB, troponin INT, and LDH. LDH is not commonly done, okay, so we mainly focus on CKMB and troponin. Now see there, the CKMB is elevated by 4 to 8 hours of myocardial infarction. The peak level reaches at 18 hours and returns to normal by 2 to 3 days. Whereas troponin, the elevation is by 3 to 6 hours, peak level reached by 16 hours and returns to normal by 7 to 10 days. So one very important knowledge here is, if the patient was brought within half an hour to 1 hour, or let's say before 4 hours, don't do cardiac enzyme that time. They may be normal. Even if myocardial infarction is there, the cardiac enzyme may be normal because they take time to rise in the blood. So first thing what I do in the hospital is ECG, and I will start the treatment from that ECG. I don't wait for cardiac marker or cardiac enzyme level. If I do that, my patient will already die. The patient is dead long time ago by the time the report would come. Okay, later on it may help me in the management. It will confirm my diagnosis and think, yes, I was not wrong. Only that type of knowledge would be provided by this enzyme. Always remember this. They don't determine our management. The management determination is done by EKG or ECG only. Diagnosis is done by this, we know that, okay, but they take time to rise in the blood. Now, as a pathology student, you should know what changes are going on in that heart, okay, in case of MI. What are the gross change? What are the microscopic change? Let's talk about it. Now, let's say this is the survival time after MI, okay. The patient has fortunately survived, then only we can study the gross changes. Otherwise, if the patient die, okay, that would be the autopsy. We cannot even know what are the changes occurring over the days or month. So after MI, within 18 hours, from 0 to 18 hours, there is no gross changes, nothing is seen. From 18 to 24 hours, it develops vague pallor and softening of that area. In 1 to 7 days, yellow pallor is developed, okay, yellow type of pallor is developed. From 7 to 28 days or up to 1 month, the central pallor with a red border, and only after a month or in few months time, it will be replaced by a foam scar. See this scar clearly written. This myocardium or myocardial tissue is an example of permanent tissue. It cannot regenerate back. Once it is damaged forever, and it is replaced by fibrous tissue in the form of scar. And only after scar form, the patient should resume the work, whatever they were doing before. Till that time, they should have very good rest at home or in the hospital. Now, let's look at this picture here. Now see this is the coronary artery. You can clearly see this is the coronary artery, this is left coronary artery, okay, left coronary artery is the right one. So this is left circumflex, this is LAD, left anterior descending. Here is occlusion, you can clearly see the occlusion is here in this area, okay. So this is the area which has high risk of death now, okay. This area will suffer from necrosis. This is called infarction, and this is how it happens. Okay. These are the schematic diagram, but they provide us a lot of information. The zone of perfusion, this is the area at risk if this coronary artery is blocked, and this is called zone of necrosis, okay, and later on it looks like this. Now what about the microscopic sequence? Okay. What about the microscopic sequence of changes? Now the survival time, if it is 1 to 4 hours, These are the predominant finding. There is wavy myocyte fiber. These are non-contractile dead fiber, okay, which are stretched by the adjacent viable contracting myocyte. So in the area of necrosis or infarction, there are dead fiber, but they are constantly stretched by the adjacent living or viable myocyte. That's why it is described as wavy myocyte fiber. That is in 1 to 4 hours. This is not very important point. Nobody is going to ask you about that. Now, this is important. From 4 hours till 24 hours, there is coagulative necrosis development inside the cardiac muscle. This is coagulative necrosis. Okay, this is very important question. They love to ask in pathology exam. From 1 to 4 day, neutrophilic infiltration. From 4 to 7 day, macrophages will come into the picture. From 7 to 28 day, granulation tissue is formed. Now see that still this granulation tissue is not known as scar. Okay, granulation tissue is a weak type of scar, you can say, or immature scar. Now patient is not safe still at this time. Patient cannot resume their job. They should take enough rest, and after a month a fibrotic scar is formed, and then this patient is fit for resumption of the work. Now let's talk about what complication can happen in myocardial infarction and what are the common cause of death because of MI. There are lots of complication development here. That's why we are very afraid of the situation. Sudden cardiac death is number one. The patient was fine 1 to 2 hours ago, okay, and after 1 to 2 hours later, the news has come that that patient is no more, he is dead now. So this is a very common story these days all over the world, and most common cause of sudden death is myocardial infarction. Now there are two important causes of sudden death. One, ventricular fibrillation, which is known as cardiac arrhythmia. Ventricular fibrillation can kill the patient within a minute, and another is cardiogenic shock. These are the two important causes of sudden death in case of MI. The second is cardiac arrhythmia. Any type of arrhythmia can happen, any type. It can be ventricular type of arrhythmia, it can be atrial type of arrhythmia. Okay, so that can also cause death, especially the ventricular type. Congestive heart failure, very common manifestation, especially left ventricular failure, and left ventricular failure leads to pulmonary edema, which is known as cardiogenic pulmonary edema, that can kill the patient. Cardiogenic shock, very serious condition. This is called pump failure. Okay, the heart cannot pump the blood outside. Just think about it. A major part of the myocardium is dead in left ventricle. That cannot pump the blood now, so there will be hypotension. Very important point. Hypotension is a most important part of cardiogenic shock. There is formation of mural thrombus and thromboembolism. Now, mural thrombus means the thrombus which is attached to the wall of left ventricle. This happens a little bit later when that area is healing. There is a formation of scar, and remember that area is not having normal myocardium, so it cannot contract. Okay, it remains still, so there is a high chance of development of thrombus, and that thrombus can detach and turn into thromboembolism. Now one small discussion here, where can it go after it is detached? Remember, it is present in left ventricle. So from left ventricle, it can go towards the aorta, ascending aorta. It can also go inside the coronary artery if it is a very smaller one, or it can go into the common carotid artery, goes towards the brain. It can go towards the upper limb or lower limb as well, or even inside the abdomen. Wherever it likes, it can go there. So it can cause blockage of the artery, which is called ischemia, and it can cause death of those important tissues. Very, very important manifestation. Another type of complication which can occur in MI is called fibrinous pericarditis. It is also known as Dressler syndrome. Okay, so let me underline and tell you some important points here. This is fibrinous pericarditis, also known as Dressler syndrome. Very important question. Now, this is the pericarditis or fibrinous type of pericarditis which develops after 2 to 3 days of infarction, okay, or it may develop even weeks later. And we all know pericarditis means inflammation of pericardium. Pericardium is the outermost layer of the heart, and this is diagnosed by auscultation. Take your stethoscope, put your stethoscope on the precordial area and listen for this friction rub. Friction rub. This friction rub means two layers of the pericardium are rubbing with each other, like parietal pericardium and visceral pericardium. They rub with each other, and a scratchy type of sound is heard. That is friction rub. And we diagnose this as a Dressler syndrome. Now, another very important complication is cardiac rupture or rupture of the heart in some of the areas. It most commonly occur after 4 to 7 days of MI. Now, what are those areas where cardiac rupture commonly occurs? One is ventricle, okay, or free wall of the ventricle, we should say. Now, our heart has three layers. The innermost layer is called endocardium, middle layer is myocardium, and outer layer is called pericardium. Okay, and we have pericardial cavity as well. Now, what will happen? See here, if this free wall of the heart is ruptured, then the blood from the cardiac chamber can leak into the pericardial cavity. Now, this condition is known as cardiac tamponade, also known as pericardial tamponade. Tamponade means pressure effect. The blood clot or the blood which is collecting in pericardial cavity is giving a lot of pressure to the cardiac chamber. What will happen now? Okay, the filling phase is a problem because it cannot dilate now. When the venous return is coming back to the heart should dilate to receive that blood. That cannot happen because some pressure is constantly given from the pericardial cavity. So this is a very serious situation. This can easily develop back pressure, okay, in the pulmonary vein, pulmonary capillaries, and can result in pulmonary edema very, very commonly. This is called cardiac tamponade. Now, another important manifestation of cardiac rupture is rupture can occur in interventricular septum. Okay, so after that the blood is coming from the left ventricle to the right. We call it left to right shunt. Left to right shunt, and this condition is also known as, okay, it is also known as VSD, but it is an acquired type of VSD. This is not a congenital condition. This is acquired type of VSD. Here, acquired type of VSD. Okay. Now, VSD is ventricular septal defect. Ventricular septal defect. So, in this condition, this is not a congenital. So that's why we wrote the term acquired there. Another condition which develops there as a result of cardiac rupture is mitral regurgitation or mitral insufficiency, and this occurs because of rupture of papillary muscle. Now, papillary muscle is one of the supporting structure of the valve of the heart. Okay, this papillary muscle is an important structure there. So if it gets ruptured, the supporting mechanism of the valve is gone, and that can easily result in regurgitation or insufficiency or incompetence. Three different terms, the meaning is same. Regurgitation, the blood is flowing backward. Insufficiency, the valve is not working properly. And incompetence, same meaning. So mitral valve is very commonly affected because of papillary muscle rupture. So remember, ventricular free wall, interventricular septum, and papillary muscle. Absolutely important question in the exam. Now, another one is a very late type of complication that is called ventricular aneurysm. Aneurysm is outpouching because that area which is dead is weak, much weaker than other area. So over a period of time, it slowly outpouches because of persistent pressure inside the ventricle. So these are some of the important complications. Now let's see some of the picture here. This is anterior myocardial rupture in an acute infarction. Here, okay, you can clearly see the rupture there. Okay. See the rupture there. Please mute yourself, guys. Mute yourself. This is a clear rupture there on the wall of the heart. Now this is a rupture of ventricular septum. See this. The wall of the heart is already cut open, so we can see the inner part of the heart, and there is a clear cut rupture. We can see clear cut rupture. Okay. Now another one. Okay, let me show you the another one. This is a complete rupture of papillary muscle. Look at this area. Okay, it is divided. It is actually ruptured after myocardial infarction. These are the papillary muscle. They are one of the supporting structure of the cardiac valve. This is fibrinous pericarditis. Okay, fibrinous pericarditis. Okay, so see this? It looks very red here, dark red actually. These are the features of inflammation there. It looks very red. Now this picture tells us there is formation of thrombus. This thrombus is attached to the wall of ventricle, so this is called mural thrombus. Okay, big thrombus is there. It can detach easily and result in thromboemboli. And this picture tells us about how thin is this wall. Just have a look here, very, very thin. Okay, this is called left ventricular aneurysm. Left ventricular aneurysm. So these are a lot of complications which can occur after myocardial infarction. Now the last part of this important lecture is a sudden cardiac death. Now sudden cardiac death, according to the definition, is death within 1 hour of the onset of symptom. Within 1 hour. Now let me explain this by giving one scenario to you. Okay, inside a family, okay, the eldest member of the family, the father, who is already 60-year-old, develops chest pain. Okay, develop chest pain, and family are like very worried now what to do, where to take this fellow, which is the ideal hospital to take. And they were talking, they were phoning here and there, they were calling the relatives what to do and all these things, and suddenly patient died within 1 hour. Patient is no more now. They cannot even take this patient to the hospital. This is a classical situation of sudden cardiac death. One situation. Another one, okay, they have heard about this. Oh, this may be a case of myocardial infarction or heart attack. This is the common term, isn't it? This is how the general public know heart attack. Now they have arranged ambulance or maybe a vehicle, and they were about to transfer the patient to the hospital. On the way, this patient died. This is also sudden cardiac death because the total duration is not more than 1 hour. So this fits in the definition, sudden cardiac death. Another situation I like to tell you, which is even more common. The patient had so many risk factors. Patient used to be a diabetic, okay, hypertensive, or maybe a smoker. After having a very good meal in the evening, okay, the patient went to bed. The patient went to bed, and he never woke up again the next morning. He died on the bed, and even family member did not know at what time he died. Okay, nobody knew. In the next morning, when they went, he did not wake up in his normal time, and they went to see what's wrong with him. He already dead on the bed. These all are different circumstances, a situation of sudden cardiac death. So let's enter into the topic here. What's the mechanism of this sudden cardiac death? Number one is cardiac arrhythmia, and the most important of them is ventricular fibrillation. It is called VF, and this ventricular fibrillation means the ventricle is not contracting, it is just fibrillating. Fibrillating means twitching of some of the fiber of cardiac muscle, and it produces a typical type of ECG wave, okay, which are called fibrillatory wave in case of ventricular fibrillation. There is no pulse in this case because ventricle is not contracting. How the pulse would be produced? Without pulse, there is no blood pressure also, and the patient will develop loss of consciousness very soon. The only treatment which can save this patient during this time is defibrillation. Defibrillation. Now you must have seen in different movies or even in the hospital. This is a special, instrument or machine, I can say, which gives shock to the patient. There are some paddle, okay. Those paddle are kept on two different areas of the chest and give electrical shock. This is called defibrillation. It can revive the patient. Another one, this is one of the most important cause of cardiac arrest. So quick resuscitation has to be started. So we need to give chest compression. The repeated chest compression has to be given. Okay, these are the two ways which can revive the patient. Otherwise, patient will die within minutes. Now, regarding the etiology of sudden cardiac death, the most important one is coronary artery disease or myocardial infarction. That's what we are talking right now. Almost 80% of the time that is responsible. In other cases, even hypertrophic cardiomyopathy can cause sudden cardiac death. It is a type of cardiomyopathy where the interventricular septum is very thick and it is causing blockage of blood flow from the aortic valve. Mitral valve prolapse or MVP is another condition which can cause sudden cardiac death, MVP, but the chances are quite less in comparison to coronary artery disease. Aortic valve stenosis or aortic stenosis is a type of rheumatic heart disease, or it can be caused by other condition also, like calcific aortic stenosis, okay, or even bicuspid aortic valve. That can also cause sudden cardiac death. Even congenital heart abnormality can lead to sudden cardiac death sometime, and even myocarditis can lead to sudden cardiac death. Now at the end, one sentence I like to highlight here: any type of heart disease can lead to sudden cardiac death. Any, just analyze this, any type of heart disease can lead to sudden cardiac death. But which is the most common one? That's the question we need to ask, and that is ischemic heart disease or coronary artery disease. And this is the topic which we are talking right now. At the end, okay, these are the questions for you. This topic is very, very important from the exam point of view. A lot of questions can be asked, okay. So I hope students would prepare this topic well and answer these questions confidently.